I'm going live on Facebook. Just another 15 seconds.
So, Dr. Atul is there, Bhavna is there, you and me, right? Vamsi will join a little later.
He's
Dr.
coming in
Rachna
5
will.
minutes. 5 minutes is coming. He's already joined, but as you said.
Yeah.
Okay.
So
And Dr. Arju Matthews is also logging in. Okay, Ravindra, we'll start, right?
Right, sir. Right.
Okay. So good evening, all. Let me welcome you all to today's webinar on expert peer exchange on biliary tract cancers. My name is Viraj Lavingya, and I'm a medical oncologist in a gastrointestinal division at HCG Cancer Center, Ahmedabad. This is the second edition after a successful first meeting with Dr. Amit Singhal on hepatocellular carcinoma. And we promise you all to keep continuing this series once a month on different aspects of GI cancers. Today we have a special guest faculty, Dr. Rachna Shroff. She is a section chief of GI Medical Oncology Department at University of Arizona Cancer Center. Dr. Shroff has focused her career on clinical and translational research in GI malignancies, and she has been PI on several clinical trials in pancreatic and biliary tract cancers. And our eminent panelists for today's discussion are Dr. Bhavna Siroi. She's a senior consultant medical oncologist in breast and GI cancers at Max Hospital, New Delhi. Dr. Atul Sharma, he's a professor of medical oncology, GI division at All India Institute of Medical Science, New Delhi. Dr. Aju Matthews, he's an American board certified medical oncologist, and he serves as the director of Kerala Cancer Care, an NGO that aims to reduce cancer disparities in India. Dr. Vamshi, he's already joined us. He's a senior consultant medical oncologist at Apollo Hospitals, Hyderabad. And we have Dr. Amol Patel. He's a senior consultant medical oncologist from Army Hospital Research and Referral, New Delhi. He holds a special interest in treating gallbladder cancers in our country. Finally, let me introduce you all to Dr. Senthil Rajappa, our moderator for today's session. Dr. Senthil is a senior consultant medical oncologist at Basotarkan Indo-American Cancer Center, Hyderabad. And today he will be leading us into a panel discussion on various aspects of managing biliary tract cancers for the next 1 hour. Senthil sir, all yours.
Or I'll share my screen there.
Dr. Shroff has joined us.
Oh, great. Dr. Shroff, let me introduce myself. I'll be moderating. My name is Dr. Senthil. I'm a medical oncologist in Hyderabad. We have 5 more panelists, or rather 6 more panelists, including Dr. Viraj. So what I intend doing over the next 1 hour is to try and share some of our own cases and try to discuss things that are of practical importance. We have quite a bit of audience on the Zoom webinar and also on Facebook, I believe. So what we will do is we will start with some cases, right? So here is a 47-year-old with obstructive jaundice. The ultrasound showed an intra and extrahepatic biliary dilatation. An upper GI scopy was done, which showed an ulcerative growth in the ampulla. The serum bilirubin, the direct was 7.8. The alk-phos was quite elevated. The CA was a little elevated. The CA 19.9 was borderline. A triple phase abdominal CT showed thickening in the second part of the duodenum with the biliary radical dilatation. He underwent Whipple surgery. Peroperatively, there were no metastasis in the liver or peritoneum. There was a growth involving the ampulla and extending to the pancreas. So this is the pathology report, right? So it's a adenocarcinoma, moderately differentiated. The pancreas and the CBD are free. The margins are negative. So the size is, as mentioned in the top right, the face is exactly coming there. So it's about 1.8 centimeter, if I'm not mistaken. So it's a PT2 N0 periampullary carcinoma. The lymph nodes are negative. So Bhavna, let me start with you. What would you do for a patient like this? Bhavna? Oh, she was, Viraj, any? Yeah, I
Yeah,
think.
so I don't see Dr. Bhavna on video, but if I can answer
Oh
this.
yeah, please go ahead.
So this is a T2N0 stage 1 ampullary tumor. Now we don't have a separate ampullary tumor adjuvant data, but the consensus statement is we treat them like a pancreatic cancer. And for a T2N0, I would consider an adjuvant chemotherapy.
So would you, yes, please go ahead, Aju.
I think it will be of theoretical importance to figure out if this carcinoma has a pancreatic origin or a duodenal origin. About 75% of periampullary are, I think, duodenal, and 25% are actually pancreatic. Just a theoretical, but I agree with Dr. Viraj. I would also consider.
Sorry, Senthil. I was
after.
Yeah. Aju, finish.
After staging scan, I don't know if
the staging scan was done, and there's no evidence of this metastasis. So, Bhavna, we are discussing a PT2N0 periampullary carcinoma. Let me tell you the immunohistochemistry that was done on this patient so that you can then take over from there. So, let me not go through that exhaustive list that was performed, but the end of that, the report was that features are suggestive of adenocarcinoma pancreatico-biliary type. So, it's a T2N0. What would you do to a patient like this?
So I would discuss, he's a fit 47-year-old gentleman. So I would discuss modified FOLFIRINOX based on the data and offer him adjuvant chemotherapy.
All right. Dr. Rachna, what would be your thoughts? Would you agree with them?
Yeah, I actually completely agree. The standard at and this is actually based out of our data retrospectively at MD Anderson about, doing the histologic differentiation. So I think that's imperative to better understand if this is pancreatico-biliary versus intestinal. And, at least, like I said, out of our retrospective data that we did at Anderson, there was kind of a suggestion that you treat the pancreatico-biliary has a pancreas-like outcome, and so you treat it similarly to pancreas. And so I would actually agree that, discussion of, and, because they're 47, I agree FOLFIRINOX is reasonable versus, a gem cape or something more easy, if you want to call it that. I don't find gem cape that much easier, frankly.
Right.
But I mean, I agree. I would, because of the histology. So I think that Aju made a really important point about that.
Dr. Atul, you wanted to make a point. Oh, okay. So you agree with whatever they said. So, all right. So let's say this was the same tumor, the low end of the CBD. What would you do, Viraj?
Lower end of CBD.
Yes. So it's an extrahepatic cholangio.
Extrahepatic cholangiocarcinoma.
Yes, correct.
So I'll tell you what I do in practice.
That's what I want to know.
So I do single agent capecitabine based
on
the BILCAP study. That's what I do.
Okay, all right, that's fine. We'll discuss the BILCAP as we go by. Dr. Atul, what would be your management of somebody with an extrahepatic cholangio? So the staging obviously would change. It's a 1.8 centimeter tumor that's just invading the submucosa, let's say. What would your management be for a tumor like that? Can you hear me?
What I was saying is that we treat it as a bile duct cancer, so it's a biliary tract tumor, so we give adjuvant chemotherapy. The gemcitabine base.
You would do gemcitabine. Bhavna, what would you do?
So I would go with the adjuvant capecitabine for 6 months.
Okay. Aju?
After BILCAP, I have shifted to capecitabine.
After BILCAP, you've shifted to capecitabine. So that's 6 months?
Yes.
Yeah.
6 months. Okay.
We're talking about the extrahepatic cholangio.
Yeah. Extrahepatic cholangiocarcinoma, lower end of the CBD. That's right.
Yes.
So Bhavna, so let's say you have somebody with a gallbladder versus an intrahepatic versus extrahepatic. Would your thresholds to start BILCAP be different, or you would say all comers, as long as they have had complete resection, would go on BILCAP?
So, BILCAP, I mean, you will discuss it later, is actually a negative study. But
We'll go to that later. I'm just asking you, will the thresholds be
no,
different?
I would, they were very well represented. And in the subgroup analysis, there was no difference. There were, I think, 70 odd gallbladder cancers as well. So I would still offer adjuvant capecitabine.
Viraj, is Amol in?
So let me ask Bhavna, you say the BILCAP is a negative study. So why do you want to go with the capecitabine?
So, I was part of recruiting into that trial for a very long time.
So it's your own baby. It's your own baby, and that's why you want
to. But you need to justify that.
It's not.
No, you just need to justify that.
I agree with you, Atul, completely. So, it's the thing was they did not stratify by the lymph node status. And when they took that into account, there was the survival was significantly, was numerically quite significantly better in patients who had capecitabine. And the hazard ratios were quite impressive. So I feel in a tumor where, this is one of the most well-run adjuvant studies, we don't have much data with other GEMs. The GEM-OX was negative. The BCAT was negative, the Japanese study. So I don't think, we have much to offer our patients. Overall, yes, intent to treat it was negative, but I think this is the best we have in a tumor which is very difficult to treat.
So Dr. Rachna, I'll give you the last word on that because you will clarify on everything, I'm sure. Let's go through the panelists before I come back to you. Dr. Atul, let me ask you, you said you will use gemcitabine, but then as much as, Bhavna said, there's a negative study with gemcitabine also. So how would you substantiate your use of gemcitabine? I'm not trying to say that I am for capecitabine. Since you asked Bhavna, I'm trying to counter you by asking you, is there good evidence for gemcitabine?
I personally believe that the gemcitabine is the better drug for the biliary tract cancer, whether this is the gallbladder cancer or cholangio and these things. So even I do understand. So from the second study, GEM-OX probably the only thing the gallbladder was probably I think had inferior outcome compared to the cholangio, the GEM-OX study adjuvant. So simply that basically.
So, Dr. Rachna, what is the reason for both of these studies becoming negative? These were both active drugs in the advanced setting, but when you put them up in the adjuvant setting, both of these studies were negative. Is it because of the statistics, long time to enroll, or you think there's something that's not clearly explained? What are your thoughts on that? And I also want you to answer to what Dr. Atul raised, saying that the forest plot for the gallbladder was exactly on the opposite side, which is something that you don't expect. Though I think it was some 18% of all patients had gallbladder carcinoma in this study. So what are the reasons you think are for the negative outcome of both of these studies? Dr. Rachna.
First of all, I do agree with Bhavna. I think that the intention to treat was absolutely negative. I think the reason that we decided for the ASCO guidelines to make capecitabine the standard is exactly because it was a pre-specified per protocol analysis. It wasn't like, what we investigators like to do, where we see the results and then try to figure out a way to make the study positive. This was just defined and described in terms of doing this kind of pre-specified per protocol analysis upfront. In terms of the GEM-OX study, for instance, usually, and this was our argument in our guidelines, I actually believe that the ACTICA study, which is GEM-CIS versus CAPE, is going to be positive. So I think that the difference in the GEM-OX study was actually, this was a very lower risk population. So it was very small, number one, numbers wise. It had a larger proportion of intrahepatic cholangiocarcinoma. And I think that if you look at BILCAP and yes, the forest plots and the analyses suggest benefit for all, I think we all know that biologically the benefit is really coming from the high recurrence rates that we see with extrahepatic and gallbladder cancers. So this was predominantly intrahepatic. It was predominantly N0 and predominantly R0. So, this was a much lower risk population. So I think to be able to see the benefit of GEM-OX was not, it was unfortunately doomed from the beginning. I think GEM-Platinum is actually very active. And I think, like I said, I think ACTICA is going to be positive. I don't know, I think similarly, I think the same thing for the ABATA study. I think these were not necessarily high risk patient populations that they were looking at. You know, I think gallbladder, and this I think is the point that everyone's getting at, and I completely agree. We shouldn't be treating all of these diseases the same. Biliary tract cancers is a lump sum type of term that is not appropriate anymore. And extrahepatic and intrahepatic and gallbladder are three very distinct entities with different patterns of recurrence and different rates of recurrence. You know, we made that little caveat in the ASCO guidelines about R1 resections, for instance, because we don't have prospective data to support this, but a lot of people with R1 resections with extrahepatic and gallbladder may benefit from radiation based on some retrospective data. So there's that. I think the BILCAP data, you know, they're doing their molecular profiling analysis. I think that will also be informative. You know, I think it's really, really important at this point in time that we factor in molecular profiling into every single study that we're looking at, both in the metastatic and in the adjuvant setting. So I think all of that will be informative.
Amol, you seem to be very much in agreement with Dr. Rachna. I'm going to come to you asking you that question. So all of us agree that it's like soft tissue sarcoma adjuvant therapy. You know, you're lumping all of them together. You know, all of them have different biologies, different recurrence rates, and so on and so forth. But unfortunately, the guideline does not say you differentiate between the anatomical site, and it says all comers should be getting adjuvant therapy. So how do you really get to a point wherein you're saying, this is what I want to do if it's intrahepatic, this is what I want to do if it's extra? I know there's no one answer, but how do you navigate through with this problem in clinical practice, Amol? Do you have different thresholds for each of these, or all comers have either BILCAP or gemcitabine or some adjuvant therapy?
So we have data which do not support strongly to use any of the therapies in the adjuvant setting. But I'm very much in agreement with Professor Atul about using the gemcitabine, which looks like most active agent in this group of diseases. From the day one, we know that gemcitabine works. And certainly, if you go by the ABC 01 and 02 meta-analysis, even in that initial first ABC 01, the gemcis was not effective in the metastatic setting. So only drug which was effective was gemcitabine. So addition of cisplatin, whether it is going to work in the metastatic setting or not, we do not know. Then about segregating these diseases, yes, they are not one disease. By virtue of their clinical presentation, anatomical location, prognosis, they were treated together, but they are genomically absolutely three different diseases. Absolutely. So we did this, the pilot study of whole genome sequencing with the Foundation One.
Well, we'll come to the molecular stuff a little later.
Yeah, what is the point? Molecular point I want to highlight, and the project is going on in my institute, is the DPYD project. So this concept came from the analyzing the proteomic atlas. In that, if you see the DPYD enzyme expression, it is maximum in gallbladder, which is compared to the bone marrow, and it is minimum in colon tissue. So exactly this DPYD's enzyme is, I'm not talking about the mutation or heterozygosity or homozygosity. So what we are analyzing at our institute is how this GemCap or capecitabine is going to affect the outcome in the patients who have more DPYD expression, and that expression we are analyzing by ISC or and the mRNA. So let's see what comes out in that study, and we may find some biomarker, which this disease, I agree this, we don't know much about what to do and is highly neglected area of research.
So we come back to where I started, Amol. How do you decide in your clinical practice who goes for adjuvant therapy? You said gemcitabine is what you use, that's fine.
Gemcis
so let's say somebody's got a 2 centimeter intrahepatic cholangiocarcinoma that's resected.
Yeah.
Would you do adjuvant capecitabine or gemcitabine in this patient, or would you not?
For 2 centimeter intrahepatic cholangiocarcinoma, probably I would just write extrahepatic. Hello.
Yeah. Go ahead, Amol.
Yeah. Extrahepatic, you will say.
No, I said intrahepatic.
Intrahepatic, I would like to observe it 2 centimeters.
So what would be your threshold if it's intrahepatic?
Though we have just written about the capecitabine and the GBC for the COVID pandemic situation, but certainly again if there's some high risk features are there, I would go for the gemcitabine.
Aju, gallbladder T2 perineural invasion N0. Would you advise adjuvant therapy or would you not?
I would definitely advise adjuvant therapy.
You would definitely advise, but no perineural invasion?
With invasion, yes. Perineural invasion? Yeah.
No, without perineural invasion?
Without, it depends on the surgeon's
I think the point I'm trying to, I'm not trying to, I grapple with this problem as much as all of you do in day-to-day practice. I think we still don't have right answers. And I want to go back to Dr. Rachna, ask her two important questions. One is, Dr. Rachna, I know you, I don't know whether you were part of the BILCAP. I probably think you weren't. But, as Amol clearly points out, capecitabine is a drug that doesn't have really great single agent activity in the metastatic setting. How did they really decide to use capecitabine as the adjuvant therapy? And they ended up winning the race also. So, that kind of bewilders me all the time. So what are your thoughts on that?
I wasn't part of BILCAP, but I do joke with Juan and John and with John Bridgewater and John Primrose that they seem to somehow have the magic sauce there in the UK and somehow end up with positive studies every time they do a study. I
thought on a humorous note, I thought they said if you want to have a negative study, you should do it in UK, and if you want to have it positive, you do it in North America. You're actually saying the other way around. Anyway, never mind. Go ahead. Sorry to interrupt you. Sorry to interrupt.
They're on like ABC 16 or something. I mean, they're like the most prolific group ever.
Okay.
No, I mean, I think I don't know exactly why they chose to use capecitabine specifically. I mean, Bhavna, if you were recruiting to the study, you may know better than that. But when you talk to in Europe, there is a definite bias towards capecitabine. I mean, all the SPAC studies with adding capecitabine to gemcitabine, for instance, and in pancreas cancer as well. And I also think, and this is why we actually put in even more specifications about dosing. Capecitabine is much better tolerated in Europe than it is, at least in America. I don't know how it is in India, but our American population cannot tolerate capecitabine with the doses that are given in the BILCAP study or say in the SPAC studies. And so that is another caveat. At least when I treat my patients, I do not use BILCAP dosing because they can't tolerate it, which is another question that I think is a really reasonable one of, do you lose? I mean, there's barely a marginal benefit, right? As we all just kind of discussed, if you want to call it that. If you're a purist, there's not a benefit. And then do we lose something by changing the dose density and the dose exposure, like in America when patients can't tolerate the doses that they use? So I don't know. These are all great questions. I don't have great answers.
Right. I know we all don't have answers. Dr. Rachna, since you were on the, you're the lead author in that paper. So just to complete this adjuvant part of our discussion today, how would you, let's say if I tell you, give us some guideline, another guideline on top of your ASCO, to say how do we really deal with adjuvant therapy in daily practice? I know the evidence is a little flimsy, but with all the background, all the information that we have, what would be your algorithms, let's say for intrahepatic gallbladder and the distal bile duct or the distal cholangiocarcinoma as they call it? If I just ask you, where would you do adjuvant versus where would you not?
Yeah, I mean, actually, I agree with pretty much everything that's been said. I mean, I think intrahepatic, I look for high-risk features, which are larger tumors greater than 5 centimeters, multifocal tumors, vascular invasion, obviously lymph node positive or R1 positive. So those are the triggers for me for adjuvant for intrahepatic. I have a much lower threshold for extrahepatic and gallbladder just because of the high risk of recurrence. And so, I mean, definitely node positive or R1 positive. I mean, those people are absolutely getting chemotherapy, but and potentially radiation depending on what the R1 looks like. But to me, the extrahepatics and gallbladders almost always I err towards, unless we're talking about like a T1 or something. I almost always err towards giving adjuvant chemo.
All right, so I think we are coming to the end of our adjuvant discussion. Viraj, you want to make any more points before I move on to the? Yes, Dr. Atul, you please make your point.
Yeah, what I would say that In our practice, number one, for all these kinds of the tumor, particularly more so about the gallbladder, they should always be encouraged to enroll in themselves into a clinical trial. At our center and in my personal clinical practice, anybody who is more than T1B or T2 onwards, I always use adjuvant chemotherapy. Right now we are doing, so right now, so there's no confusion in that. Right now we are doing a clinical study comparing chemotherapy versus chemoradiation for
Very
all
nice.
such patients.
Okay. Great. Viraj, anything you want to add before I move on?
No, let's move on, sir.
Okay, great. So I think though we haven't been able to give you a clear, clean guideline on who should undergo adjuvant therapy, our jury seems to be divided between capecitabine and gemcitabine, and that's what the NCCN also seems to be, because it, although it says capecitabine is a category 1 based on the BILCAP study, it gives you a big list of other options on the right side, which all of us can use in our appropriate patients, especially if you think a patient can't tolerate capecitabine itself. We are also not able to clearly say that what criteria should be used to decide on adjuvant therapy for somebody with a cholangio versus somebody with a gallbladder. I think it has to be very individualized in terms of the risk of recurrence based on the pathology, the general condition of your patient, and what ultimately your patient wants, understanding the background in terms of what data is available. So I think individualized GEM or CAPE should be the way to go. So that's where we would end that adjuvant and then go on to our locally advanced disease. So this is a 45-year-old with a right hypochondrial who presented with the right hypochondrial discomfort, and that's the huge lesion that is sitting there. It's in the gallbladder fossa, infiltrating the liver, abutting the hepatic flexure, gastroduodenal junction, a poorly differentiated carcinoma, CA19-9 elevated alpha-fetoprotein, CA normal. A PET CT was done, not showing any evidence of distant metastasis. Vamsi, you've just now joined in. Would you call this palliative, or would you call this neoadjuvant?
Yeah, I would actually call this a kind of a palliative setting. A neoadjuvant has not really shown great results. You can convert into probably 20 or 25, 20 to 30% only. So with this kind, actually, I'm not able to really appreciate the vascular invasion, but it looks like it might be involving it nearby. What is that there, Dr. Sendil?
Which one, Vamsi?
The vascular invasion. So if there's a vascular invasion or your portal vein is totally involved, then definitely it becomes a palliative setting.
You're saying you would want to get some more reconstruction images before you decide what you want to do.
Because of vascular,
All right, so you're saying you would start with palliative intent and then convert it to neoadjuvant if there's dramatic response. Is that what you're saying?
Senthil, do you something in the lung on the right side?
Okay, so the reason why I put that up is that is CORADS 3 lesion, sir. So that's the flavor of the season, you see. Everybody who comes in will have something like that in the lung, and then you go chasing that. So that's CORADS 3. Very nice. I'm glad you observed it. I wanted to bring that up a little later. Amol, you've got some experience in this area, at least more than many of us. So what are your thoughts on it?
So again, I would say, in fact, before you're concluding about the adjuvant, I wanted to say something is, let's participate in clinical trial. Now for this scenario also, I think Professor Atul again is leading one trial, is a small study of neoadjuvant, where you have to convert this inoperable disease into operable one. So whatever the data is there, the data is scant. We don't have much literature, but certainly the encouraging response rate with the modified FOLFIRINOX in such situation, yes, it makes sense to use such kind of therapy in patients who are performance status with 0, 1, and see what happens. I will encourage for all such patients to enroll in clinical trial. In fact, the NCCN slide are highly inadequate. They are not based on any class 1 recommendation.
Absolutely. I think NCCN agrees with that.
And no masters from the India or the people who are treating from South Africa, they are there. And the people who are sitting and just mentioning something, and it is so horrible to see the GB or biliary tract. It is not their concern. It is our concern.
Absolutely.
So I would prefer to enroll patient in clinical trial for this case.
Absolutely, Amol. But would you think that outside the context of a clinical trial, you would look at this with a potentially curative approach in a very small group of patients? No.
Yeah. So what happens at my institute, to just share my experience, is we discuss this case with the surgical oncologist first. And if the adequate response, if he is expecting that the major vasculatures are not involved, and he says, yes, there is a chance that the patient may go ahead with the surgery, which responses we are going to see, and then we go ahead with the either sometimes the GemCis or a very good PS, then yes, FOLFIRINOX.
Viraj, your thoughts?
Yeah, so for such patients, I have a personal experience with triplet using gemcitabine, cisplatin, and nab-paclitaxel.
Okay.
We have a good phase 2 data from Dr. Rachna Shroff's institute, and there is a phase 3 going on also in metastatic disease. I had an excellent result with a triplet, and we could actually manage to convert him. Of course, the long-term results would be, we will see. But what I feel in locally advanced disease is the non-regional lymph nodes, you know, the nodes lying between aortopulmonary window, retroperitoneal node. These are the ones which I don't think so we are able to convert them, but only for the T staging, I think so we have good success with chemo alone.
All right, Dr. Rachna, your thoughts on that? I want you to tell me two important things. One is, should we be doing this only for gallbladder cancers as the NCCN's recommendation says, or you would extrapolate it to the extra gallbladder, cholangiocarcinomas also, number one, and what would be your regimen of choice?
Yeah, I fully agree that I think we need systematic clinical trials to answer that question. I will say that the U.S. as a whole is starting to shift towards a neoadjuvant approach. I think it's just extrapolating that from pancreas and, gastroesophageal malignancies and such. The FOLFIRINOX is a great regimen. That being said, the PRODIGE study has been stopped. So, the frontline study, FOLFIRINOX versus gemcitabine, phase 2/3 has stopped. So it did not meet its phase 2 primary endpoint. And so they have not presented that data, but we know that from the IBPCC. So I don't know exactly what happened there, but I think that's important to note. Maybe going back to what somebody was saying about gemcitabine being a better therapy for biliary cancer. I think in the neoadjuvant space, there's a study going on here in the United States, which is a multi-center study at kind of high volume centers for what they're calling high-risk intrahepatic cholangiocarcinomas with the triplet, GemCis, nab-paclitaxel, and that's based on the 20% conversion rate that we saw in our phase 2. I think that is going to be an informative study. It's a feasibility study to make sure that this, people can get the regimen and then go safely to the OR. So that's really the endpoint. I think that study will help inform what we do in the States next. I can tell you through the NCTN, we are shifting to perioperative therapy. So there's a number of studies that are currently, that we are presenting to the task force, the hepatobiliary task force, that are either kind of pre-operative GemCis or GemCis nab-paclitaxel in biliary cancers. And so I think that we're going to start seeing more and more of these studies to answer those questions. Given the response rates I've seen with the triplet in a patient like that, where I would absolutely go in up front and say, look, this is palliative therapy, so that we go in eyes wide open. But I would give, if they're able to, I would give GemCis nab-paclitaxel to see if we could convert this to a potentially resectable and curative therapy.
What about extra? Go ahead, Amol.
In fact, sorry, okay, after you.
And we have forgotten here the 5FU now.
I will come back. we leave capecitabine and then go forward. I think all of us understand that there is a problem with all these data. We all have our biases, and so do you. So I think we'll move on. Bhavna, please make your point, and then we'll.
So no, we published from Tata Hospital. I think that we were able to downstage about half the patients with GemCis, and also I think Reena published with the neoadjuvant chemoradiotherapy, and now they're comparing within the POLO trial neoadjuvant GemCis versus gem radiotherapy for patients exactly like this, So we actually defined criteria for borderline resectable gallbladder cancer. So, and this does look like borderline resectable because segment 4B5 seems to be involved, and rest everything is fine.
Okay, good. Viraj, what are your indications for radiation therapy in patients with cholangios, gallbladder?
So except cut margin positivity, we do not do radiotherapy in our center.
Lymph nodes?
No adjuvant radiotherapy.
Anybody, Vamshi, you have a different opinion on that?
No, not really. One thing we know that in adjuvant, if you want to give, do not give radiation alone. You either give chemotherapy or you give chemo radiation, or you can sequence both of them. Radiation alone we will not be using. Personally, I would use it only in a R1. I do not think using in a node positive gives a huge benefit over chemotherapy. Okay. Combining the two again, I don't think the SWOG study did show some benefit, but I am not sure if that will be a routine practice. I would just give chemotherapy.
Dr. Atul, your thoughts on adjuvant radiation therapy? Of course, with chemotherapy, let me make that point very clear. It's not radiation therapy alone. Where would you add radiation therapy? You have to unmute yourself, sir.
You're talking about the gallbladder in general?
Gallbladder, intrahepatic, extrahepatic, of course, not in intrahepatic.
So gallbladder, our policy is very much clear. So we always enroll them into clinical trial.
Okay.
If I have to treat outside the clinical trial, then I'll just use the adjuvant chemotherapy.
Right.
In the clinical trial, we are randomizing between the chemotherapy versus chemoradiation.
Very nice. Okay.
So that is one
and what are your indications outside of a clinical trial for radiation?
So if this either the margin positive, that is R1, or node positive.
Okay, right. So that seems to be what the book says, at least, that even in patients with N+, again, based on very flimsy evidence, there is some recommendation for radiation. So we'll move on. So just to summarize this part of our panel discussion, anybody who's got a localized gallbladder carcinoma, locally advanced, borderline resectable, whatever you may want to call it based on your criteria, should start with an effective chemotherapy regimen. I don't want to again comment on the regimens. Atul will, not Dr. Amol will spring up from my screen to, hold my throat. It looks like Amol. I totally agree with you that you should be comfortable in whatever you're doing. Good response rate is very important because that's what ends up in conversion therapy. Because if at all there is a small chance of a cure, it comes with surgery and not just with chemotherapy alone. Again, there is some disagreement on who should get radiation therapy. Dr. Atul says it's node positive plus R1 resections, while Viraj and Vamsi think it's otherwise. Again, we really don't have large volumes of high quality evidence to substantiate that. We'll go with... yes, quickly.
Like Amol was hinting this thing. So what we have done is basically we have finished a work on the pilot study of 20 patients with metastatic for gallbladder cancer, modified FOLFIRINOX, ECOG-01. We have really seen good responses, 45% objective responses. 2 patients were subjected for the surgery. One probably was one underwent this thing, R0 resection. The second patient, there were other comorbidities, so they opened up and they were able to take it out. They were supposed to take it out, but because of other complications, they couldn't. So we have sent this paper for manuscript for publication, and hopefully we'll have some result in maybe the 1 or 2 weeks. It will be published somewhere.
Right.
So if that is there, then probably our next project will be modified FOLFIRINOX in the new adjuvant protocol.
Right. I think that makes a lot of sense. Dr. Rachna, let me ask you this question. Here is the patient. I just put this scan as a representative scan. This is not actually the scan of a patient, but let's say somebody who's relapsed with a solitary liver met like what you're seeing here after just over a year of adjuvant therapy for gallbladder cancer. What would you do in a patient like this? Would you just wait and watch because it's asymptomatic, or would you do locally ablative therapies plus minus systemic therapy? What would you do in a patient like this?
So, I mean, in somebody that has what looks like an isolated recurrence, this is after a gallbladder, you said?
Yes.
Yeah, so I mean, I would worry that they're going to get more than just that. So I would not feel comfortable starting with local therapy. What I would probably do is I would biopsy and sequence, get next generation sequencing going. And then our typical, we had a study that we looked at, and this was then being studied in the NRG that we did at Anderson, where we basically would start with Gemcis, for instance, some sort of chemo, make sure that we had control. So 3, 4, 5 months of chemo. And if that was all that was there, then we had we would offer radiation. So especially in a peripheral lesion like that, you can give ablative doses. So we published in JCO about our ablative regimen, which was somewhere upwards of well above the 50.4 gray. It was anywhere from 60 something up to 75 gray. And the local control that was seen was really remarkable. So we would think about something local after we get chemo in and make sure that there's not further disease that's going to come.
Aju, would you agree with that? Or would you start with some local therapy and then go down to systemic therapy? What would be your thoughts?
In my experience, these cancers can actually behave in a very heterogeneous way. Some of which will just drive through the patient very quickly. Some will just go on an indolent course. So the time of recurrence despite chemotherapy worries me. So I think I will discuss systemic therapy with this patient.
Okay, so systemic therapy first, watch what's happening and then decide on whether you want to add local therapy or not. I agree with all of you that somebody who comes back early with disease is probably got systemic disease which is manifesting locally like this. So systemic therapy should be the way to go, and then you get on. Right, so we'll get on to the metastatic setting. We've got about 20 minutes, 25 minutes to go. Here is a 20-year-old male who presented with pain in the right hypochondrium of 3 months duration, some weight loss, some low-grade temperature. And this is what the scan showed. This is a PET CT scan which is showing multiple left lobe lesions. Largest was 4.5 centimeter. There was a small right lobe lesion also. Multiple lymph nodes in the abdomen extending up to the iotocaval lymph nodes. There was a lytic lesion in the right acetabulum and left small supraclavicular lymph node. So there are scans on the right and the left. I've also put up the cut where you see the acetabular lesion. So it's certainly stage 4 disease. There was a lot of disagreement on pathology, and then we finally sent the blocks to Tata Hospital, and it was confirmed as an intrahepatic multifocal intrahepatic cholangiocarcinoma with all the immunohistochemistry that I have listed up there. We still did a colonoscopy and upper GI endoscopy. The CA19-9 was high. All the other tumor markers were negative to begin with. We just did the HER2 and the MMR, which were proficient. So the diagnosis was an intrahepatic cholangiocarcinoma stage 4 in a 20-year-old man or a boy or whatever you want to call that as. So let me start with Amol. Amol, one of the things that we very frequently come across is that these, not this patient in particular, but in general patients with the biliary tract cancers come to us with obstructive jaundice, and then you put a stent. What would be your threshold to start off chemotherapy in terms of the level of bilirubin? Amol, are you around? Yeah, there you are. Amol, you have to unmute yourself. Yeah, there you are.
So very good question. Many times in clinic, we see these patients with bilirubin 15, 12, 25, sometimes 7, 5, all ranges. And we keep losing a lot of time. And when I joined Army Hospital Arendar, so that time one of our patients received gemcitabine at bilirubin 20. Though he was a case of CS stomach, and somehow he responded well in a second line. So that led me to review the literature about drug modification for both gemcitabine and cisplatin. I did not find any such recommendation. So for me, PS is the big factor. If the performance status like our soldier comes with 0 or 1 PS, even with the bilirubin around 10 or 12, I start with gemcitabine. If firstly, we'll take a review, and if the GE physician is very comfortable in putting the stent, the anatomy is very feasible, then certainly yes, we go for that. And many a times there is first attempt which fails for the stenting. In such situation, I straightway go for gemcitabine. And with the kind of whatever responses I get, some bilirubin goes down, and at around 7 to 8 bilirubin, I start adding cisplatin. So with this, I could salvage around for 4 patients, though it's a very difficult situation. So it's just anecdotal. It's our own experience. I thought that this kind of a concept should be enrolled, and we should see what happens, because lot of our patients, they do not get any subsequent therapy. Almost 60% they are out of therapy.
You're correct. Bhavna, what's your threshold? What would you do?
Actually, disagree, Amol. Basically, if a patient comes with a very high bilirubin, like you said, in their 20s, I would see if there is intrahepatic biliary duct dilatation, and if one could do biliary decompression. So once the bilirubin shows a downward trend, I would prefer to use dose-reduced gemcitabine cisplatin. But my threshold is that I wait for the bilirubin to come down to below 5. If patients have extensive hepatic metastasis, which is leading to at least more than 3 to 4 times upper limit of normal bilirubin, I would actually discuss best supportive care with that patient rather than pushing for chemotherapy. And so I would wait for the bilirubin to come down to 5, but I would love to hear what the others say.
Viraj?
So I agree. I see alkaline phosphatase and IHBR in my practice. If it's an obstructive jaundice, then I do decompression and
all of us would do decompression, Viraj. Let's go to
so
the
if
threshold.
it is obstructive, then like Dr. Bhavna said, best supportive care.
Okay.
But if it is obstructive, then we will do decompression, and the moment it starts declining, within a week I put them on chemo. So in my practice, I have done at 15 also.
You have done at 15 also, so you won't really wait. So
but
you
it was declining. It was declining.
Yeah,
it was
obviously.
declining. So I think the trend is what is important. The absolute value is not important, is what you're saying. Vamshi, you would agree with that?
Yeah, I mean, I just have a question. I have probably never seen a patient with a non-obstructive with bilirubin of 15 with a PS of 0.1. I don't think we ever see such things. The patients would not be in a position to tolerate. It's a PS 3 or 4. Having said that, we, in desperation, do try giving gemcitabine. I do the same thing what Dr. Amol does. We tell them to for best supportive care, but then in practice, yes, some small dose of gemcitabine if patient really wants, but not a standard of care.
Okay, so you don't want patient wants, we'll do some gemcitabine.
If patient wants, but not a standard of care. First option is best supportive care.
All right, Dr. Rachna, Doctor, we'll come back to you, Amol. We'll come back to you. Dr. Rachna, what is your practical approach to a patient who's been stented? Bilirubin is starting to fall. What would be your threshold to start?
Yeah, I mean, assuming that this is all based on obstruction, I feel comfortable giving gemcitabine usually when it gets at least below 10. I prefer below 8 because I agree. I actually don't think that PS is usually well enough to give chemo until it gets down to that range.
All right, and any dose adjustments for gemcitabine?
And yes, and then I dose adjust. I don't use a lot of 1,000 milligrams per meter square of gem anyways, but yes, I would dose adjust for sure until it gets down to even less than 4, 3. I would dose adjust.
Okay, so let's go to Dr. Atul. Atul, sir, which is you said gemcitabine is your drug of choice. Which platinum would you add with the gemcitabine? There is some data for carbo, there is some data for cisplatin, oxaliplatin. Do we know the right answer?
So I think this is oxaliplatin.
You like oxaliplatin, but the NCCN probably does not think so. I agree.
Doesn't matter. We
doesn't
have
matter.
Publication.
Very well said. Doesn't matter. Absolutely fine.
I said whatever the NCCN said, that doesn't make a difference.
That's correct. That's what I also reiterated.
So we have our own publication.
Great.
For the gemcitabine oxaliplatin, comparing the best supportive care. We have an equivalent study comparing gemcitabine oxaliplatin versus gemcitabine cisplatin,
right,
which says numerical survival may be better. So it was the equivalent study. We could not prove the equivalence of the GemCis to the GemOx, and numerically the survival was better in GemOx.
Right.
The responses are slightly better in GemOx. So, but anyway, I leave it to I think there are differences.
Absolutely. I think there's no one correct answer. It's purely based on opinion. Yeah. That's absolutely correct. Vamsi, cisplatin, oxaliplatin, carboplatin.
So I would prefer, I usually give either GemCis or I give GemOx. There is no absolute answer in this. Again, it kind of depends on the patient.
How do you choose one?
So if patient has a good performance, obviously, I generally use GemOx based on Dr. Atul's papers. And since it's from India, I kind of stick to it. So GemOx is my first choice.
Excellent.
But that's fair enough. I mean, I go with because it's from India, and I think that's
Be Indian, buy Indian, now make in India. So great.
Chinese have not yet gotten here yet. The Chinese don't have studies here.
We'll make
So
sure
we
they
can
don't.
be happy to.
We'll make sure, at least Amol will make sure that they don't get in anywhere
Yes.
close to Galwan anymore. I am with Amol. I am with Amol there. Okay, Bhavna, let's. So I think there's no one correct answer. It's either between oxaliplatin and cisplatin, it looks like. So it depends on what you're comfortable with and what you believe in. So there's no one right answer. Again, I don't think we are finding a right answer to any of the questions that we are asking today, Amol. Right? Everything seems to be based on opinion. Everything seems to be based on opinion.
Senthil, yeah, that is the single reason that we need more and more work from India.
I totally agree.
Yes.
I agree. I agree very much. I think all of us agree with you, sir. And we are very happy to collaborate with you. Please.
Dr. Senthil, I have form GBC working group, WhatsApp group.
Okay.
For last 1 year. And I'm the only one who puts the misses in there.
Okay, so I will at least say good morning from tomorrow. If not, I may not be academically useful, but at least I'll say good morning to you. Okay,
Pandey did a very good study from Patna.
Okay.
It's an institutional analysis. Avinash.
Yeah. Right.
So,
Viraj, I think we should.
Yeah, gallbladder.
Viraj, what about molecular profiling at the time of diagnosis of metastatic disease? Would you selectively test? Should it be a hotspot? Should it be a broad panel? And I also want to ask you, how do you integrate the findings of that genetic testing? Or when I say genetic, I'm talking about NGS for your first line therapy. Yes, your molecular therapy first line.
So for first line, I do not use molecular profiling, although I do send the sample for in the beginning for using plan B and plan C. Okay. And typically what we are looking at in any biliary tract cancers is the 5 to 6 alterations like IDH, BRAF, FGFR, HER2, MSI, and now DNA repair mechanisms. So these are the alterations of interest that I look into, but I do send a broad NGS panel.
All right, so broad panel at diagnosis, but no incorporation of this finding into your first line therapy. Amol, one quick answer is, do you agree with Viraj? Or you have some ways of, I know you have a trial that's running. So out of a clinical trial, would you incorporate this information into clinical practice, first line therapy, or you would say gemcitabine plus a platinum is what is standard for me?
So as far as the data is concerned, so I would just recommend whatever the evidence is there for HER2 testing, HER2 testing.
Right.
That is one. And second is I would recommend for FGFR2 rearrangement or amplification for the intrahepatic cholangiocarcinoma. So apart from these two testing and the targeted therapy available, we do not have much evidence to support, including MSI or PD-L1 or the other all molecular markers, or for that the targeted therapy we don't have. So whatever we
let's say somebody has got HER2, Amol, would you add some anti-HER2 therapy along with your chemotherapy first line, or when would you push that in?
So we did this study in second line, saw the responses. So obviously it is time to get into first line, and whatever we have published this year ASCO about analysis of around 32 patients. In that 14 patients received those from my institute. This was a structured study, we collaborated. So they were in second line and the other patients were in the first line. So encouraging PFS and the OS were there with the first line use of trastuzumab with the Gemcis or Gemox. Some patients do receive the
please, Dr. Rachna, I was going to come to you next. So would you do broad molecular at the time of diagnosis? I want the second question is how do you incorporate it, especially the HER2? The second, the third is are these very stable molecular alterations that occur at the time of diagnosis, or are they dynamic issues and you don't want to keep doing them again and again? So when would you say is the best time to do?
Yeah, so I absolutely do molecular profiling, full next generation sequencing, broad panels at the time of diagnosis. I actually strongly disagree with that statement, though, about HER2 and FGFR being the only relevant targets. So first of all, FGFR amplifications, completely negative in cholangiocarcinoma, only FGFR2 fusions. HER2 amplifications, absolutely. IDH1 mutations, we have a published phase 3 study. And MSI high is a tumor agnostic indication. Yes, it's only about 1 to 3% of biliary cancers, but it's still 1 to 3%. BRAF, 3 to 7% of intrahepatic cholangiocarcinomas. The ROAR study, strikingly impressive overall response rates with dabrafenib and trametinib. So I actually think it is much more than just FGFR and HER2. That's why I do broad panels. I do it at the time of diagnosis. I usually do not integrate targeted therapy until progression on GemCis. I always use cisplatin. I don't always, but primarily use cisplatin. There are a number of frontline studies across the country, across the world right now, but that we are participating in for FGFR inhibitors in frontline. So comparing an FGFR inhibitor to gemcitabine and cisplatin in the setting of an FGFR2 fusion. So in patients in whom I think I can wait, because that's the hardest problem, is can you wait to receive NGS information prior to starting systemic therapy. So in patients in whom I think it is safe to wait, I will try to see, we'll try to do NGS and then integrate FGFR inhibitors in a clinical trial setting only in the frontline. There are frontline studies planned for IDH, HER2, and there's a lot of course, immunotherapy frontline studies. So I think all of that information will be helpful. In terms of the timing, the majority of the alterations that are found, FGFR2 fusions, IDH, and BRAF and HER2 are thought to be early oncogenic drivers. So we see them early on at the time of disease. You will find them at the time of diagnosis, and they remain even at the time of progression on post-progression biopsies and in rapid autopsy specimens. The only thing that we see that changes is in patients treated with FGFR inhibitors, for instance, and people and things like IDH, you do see polyclonal resistance emerge. And so there's a utility to ctDNA. There's a lot of interesting data for FGFR inhibitors and resistance and how to sequence the FGFR inhibitors based on the evaluation of the polyclonal resistance, and to see if you should switch from an ATP binding inhibitor to a covalent binding inhibitor, for instance. So I do sequencing up front, and I consider post-progression biopsies only if I think it will help me understand resistance in those settings.
Very nice. I think that's very, very clear. So gemcitabine, cisplatin / oxaliplatin is our treatment of choice. We will do next generation sequencing, a broad molecular profiling to look for all of these targets that Viraj and Dr. Rachna have enumerated. So the point is that all of these are very stable. They occur early, so it's fine to do them early during the course of the disease, though we would not incorporate this in the management plan in the first line, at least as of now, because there's no good prospective clinical data. All right, so this patient went on gemcitabine and cisplatin 6 cycles, near complete response, right? So question number 1, the patient asked for surgery because it was a 20-year-old, but logically we would not suggest something like that for a patient who had metastatic disease at the time of diagnosis. So we didn't do surgery. The question is there a role for any maintenance therapy in a young patient like this with lots of disease at the time of presentation with very good response to gemcitabine and cisplatin? Dr. Atul, what are your thoughts on maintenance therapy?
So probably you don't have any evidence for maintenance, but this also probably we are trying to study. So in next protocol, probably we are randomizing between the gemcitabine versus gemcitabine platinum versus FOLFIRINOX. And the second randomization, we are thinking of maintenance therapy. And this maintenance will be either the capecitabine or erlotinib. So as of now, I vote outside the clinical trial. I don't think there's any justification or indication for maintenance treatment.
Absolutely, but yeah, go ahead, Vamsi.
So just a thought for the day. I mean, gemcitabine has worked so well. There is some data. Can you keep? I mean, there's no data on it, but would you want to consider gemcitabine itself as a maintenance? Keep giving it once in 2 weeks.
That's the question I'm trying to ask
you.
So would you do? You would do it. All right, fine. Viraj.
I would probably be inclined to do it.
Okay, I'm telling you, I did it. So now you can tell me what you
I would be inclined to do it as well.
Very good.
Anyway, you could have gone ahead with the 6-8 cycles.
$1 million question again. just like oxaliplatin versus cisplatin, it looks like.
No, if you probably are you buying this idea from the GEMS ABC study, then I believe they used 8 cycles.
Okay, so I'm not. The answer is I don't know whether 6 versus 8 will make a big difference, but I did 6 cycles, so that's what I did. Viraj, you would also think of maintenance?
I would continue gemcitabine until myelosuppression becomes a problem.
Very nice, Bhavna. Unmute yourself, Bhavna.
So I tend to stop at 6 to 8 cycles. Okay. And but if a patient, like I have a patient currently who's very young in his late 20s, he's recurred after 8 months and has again had a fantastic response to Gemcis.
We'll go to that. We'll go to that.
I'm continuing with him actually, but
yeah. So
I would not.
Okay, you would not. Dr. Rachna?
Yeah, I have a tendency to move to maintenance gemcitabine. Admittedly, no data to support it, but I think it's just patients like a break. And I mean, I'm not actually arguing with the ABCO2 approach. I mean, in a patient-by-patient basis, sometimes I move to maintenance gem and sometimes I stop chemo.
Right. So I think it's an opinion that in selective patients, it's not wrong to go ahead with maintenance as long as patients agree that this is not standard of care and they're able to tolerate whatever we're doing. So this patient went on maintenance, and that the one on the left is the scan that was done in March. And then he went on maintenance for nearly 6 months. And the scan continued to show a maintained good response as we had seen in the previous one. But lo and behold, at some point in time, it has to start increasing, and that's what happened. So this patient started showing an increase in the left lobe of liver. You see those lesions there again, and then some lymph nodes started showing up. So this was nearly after 6 or 7 months of maintenance therapy. So what would you do, Viraj, in a situation like this? Get the cisplatin back, as Bhavna said, or would you change to irinotecan/FOLFIRI with Anand's data that was read out at the recent GI conference?
So I agree, some sort of second line chemo, but I would do a molecular profiling of this patient.
Already done, let's say, and nothing is showing up.
Common scenario.
Yes.
Well, I think if you combine all 5 or 6 alterations that we just discussed, I think so 1 in 3 will have some alteration.
Okay, let's say somebody had it, and I believe, I just was looking up before this panel, Ivosidenib costs $1,000 a day. Right?
I do have an IDH mutant and we couldn't offer it.
That's the point I'm trying to make. So we'll come to that. That's why Amol is laughing loudly.
Absolutely. That's why when
I agree, Amol. We'll come to that. We'll come to that. Let's look at the reality. The reality is, yes, though I agree that some patients will have these alterations, the reality is wherever you are, access to therapies and affordability is always a problem, and then we fall back on our good old chemotherapy, which still give us good results. So let's say none of these alterations, your patient is not a candidate for targeted therapy. What would you do?
I would do irinotecan.
You would do irinotecan. Bhavna, what would you do? Cisplatin back?
So if a DFI is more than 6 months, I would go for, So I would go for platinum. Otherwise, Kapivi is a good choice.
Okay. Aju?
I would still reintroduce cisplatin at this stage.
Reintroduce cisplatin. Dr. Rachna, what would be your one-line answer to that? Reintroduce or change?
Yeah, I think because it's been some time, I would add back the cis first.
Right. So what we did is we actually reintroduced the cisplatin. So let me quickly ask Dr. Rachna this question. Dr. Rachna, this is the NCCN's guideline, which talks about gemcitabine platinum first line, and then it talks about oxaliplatin in the second line. Does that make a logical choice? Is it based on some data, or is it just some opinion? What is that?
Well, now it is based on data. I mean, it's based on ABCO6. I will tell you that my bias tends to be to use FOLFIRI in second line as well because of that exact thing. But it's not necessarily, I don't necessarily think of it scientifically. I actually just think of giving patients a break from platinum. So I have a tendency to know that I can still use oxaliplatin. So I will go to FOLFOX eventually because we don't have that many options. But I have a tendency to move to irinotecan. But technically, and I see that 5.3 months to 6.2 months is not a dramatic improvement in median OS, but technically it was a statistically significant study, again, for the ABC group. So there is data, but I don't necessarily do that in practice.
All right, so good. So we tend to use irinotecan, though there is data for oxaliplatin after gemcitabine cisplatin. Vamsi, gallbladder cancer, if you get your disease back, single agent therapy is safer compared to combination therapy. So would you do single agent or would you do combination in a patient whose performance status is still good?
So again, if the performance status is good, I would tend to give a combination more out of hope and the fact that yes, I'm doing more. But in reality, I would think most patients go on a single agent. I think that's what happens in practical. Yeah, that's practically what happens. They don't really tolerate a combination that well. So I would still be okay with a single agent.
Dr. Atul, what would be your choice for second line therapy in patients like this?
So I was part of this SELECT study, which was led by Anant and this thing Vikas. So I probably, obviously, until that, probably I would be using 5FU base because I don't use 5FU in the first line. So subsequent to that, probably our practice is if performance status permit, then they probably may go for the two combination, which most of the time I personally use FOLFIRI. If otherwise, it's a single agent irinotecan.
All right. So we all tend to use doublets for patients who have good performance status, but will use single agent therapy for patients who are not doing that very well. I think that point is very well taken. That's what all of us would do in clinical practice. So Viraj, let's say you want to do IDH1 and then you got your hold on the drug. Doesn't matter. You got somebody from the Ambani family who's your patient and will be able to afford $1,000 a day. Right. So I just want to, I don't even know how that looks like. I'm sure only Dr. Shroff here has seen it and done it. So I just read some numbers here. The number one is that it was a placebo controlled study. The PFS was 2.7 versus 1.4 months, though the hazard ratio was great, 0.37, 2.4% overall response rate, 10.9 versus 9.7 is the median overall survival. So the 6 and the 12 month, survival seems to be, PFS seems to be better on the targeted therapy arm compared to the placebo. So do you think, number one, it was appropriate to randomize with placebo when all of us are now saying that our second line, third line choices in a patient with good performance status would be chemotherapy, number one? And do those numbers really impress you to put your money on something as expensive as that? My personal opinion is no. So I just want to ask the opinion of the panelists. And then finally to Dr. Rachna as to, how she goes about grappling with this data.
So ivosidenib, of course, I agree with you. It's like regorafenib for colon cancer. It does not cause response rate. It just causes stabilization of disease. And I do believe that the benefit is modest at best. But I think IDH targeting will be future for this biliary tract cancer. May not be ivosidenib, but some other molecule. But if you see BRAF, on the other hand, the responses are very potent, very deep, and very durable. Like in Roche study, we had 40% response rate.
That's good.
And now we also have a DNA repair alterations like ATM or CHEK or RAD1, where we are using olaparib. And I think this trial is ongoing. And there are some deeper responses seen with this targeting also. So I think the future looks bright. And olaparib is available in our country in not so very expensive way. So we are hopeful. In fact, I do have a patient on ATM mutation, and he's asking me whether should he go on olaparib.
Okay, Vamsi. So Viraj has answered typically like an ASCO post interview, modest benefits, but very exciting. We will look forward to more data, right? So what are your thoughts on that, Vamsi?
I think practically speaking, leaving aside the academics part of it, practically speaking, these drugs are pretty expensive and the benefit they're giving is modest. Olaparib is giving slightly better results. I would go with that. The other thing which you have added also I agree with. My only other question which I would want to actually add, because how many patients are we getting this MSIH high, such an agnostic approval with, in the trial there were 60 or 80 patients, of which 2 or 3 would have been this disease. And
no, not a single one.
Not a single one. So there you go. And we are pushing Pembro also in this line where I don't think it really works. So overall, I'm not very sure that these are the exact things we target. Yes, academically speaking, all of them are good.
And then TMB is added.
Speaking, I don't think so.
TMB is added to that agnostic approal now, Vamsi. So you'll have to add that.
Yeah, I mean that TMB approval is something I don't want to get into here.
You don't want to get into. So that says it all.
Yeah,
so let me. We are running out of time. We've got 5 minutes to go. I want to, ask Dr. Rachna. Dr. Rachna, how do you've heard about, you may call us skeptics, nihilists, except probably Viraj who's sitting there. But, that's the impression that we get when we look at data like this. You've done it. So, can you just tell us, what promise does all of this hold, and has it really made an impact on your patient care?
Yeah, so I mean, I think you have to look at it category by category. So if you want to talk about IVO, I mean, I think what's great about IVO is it's actually much better tolerated than regorafenib, for instance. I mean, it's got a very great toxicity profile. It is absolutely a cytostatic drug. It has much more stable disease and response. But, I mean, the patients I put on Clarity had CA19-9 response and a clinical benefit. So to me, what I always tell my patients is this is not breast cancer. I don't have 27 different drugs. So if I have an IDH mutation, I'm going to absolutely, and I admit that it's very different in America than it is in India in terms of my access and cost of these drugs, because I have expanded access programs and things like that where Agios can give me the drugs for free. So, but I will absolutely use IVO,
right.
And I will use it probably second line as opposed to third line. I agree with you that the placebo arm was troublesome. That's why when we designed the study, we made sure that there was crossover within 6 weeks. That being said, the study was designed before the FOLFOX data was out. And so as a result, the agency did not let Agios have any other standard control arm. They would not approve any other design. So that's IVO. I do completely agree that the next generation of IDH drugs, the Loxo drug looks really exciting and promising. It's not in the clinic. I mean, that's based on preclinical data, but it looks like a really good IDH inhibitor. And I think that will be intriguing once it gets into the clinic, which is happening this year. The pembrolizumab, I completely agree. The TMB high agnostic approval is really irritating to me. We don't even know what TMB high means in this disease, and that's a whole nother level of frustration. I completely disagree, however, that in the initial Keynote study, while there was not MSI high, there have been MSI highs since then, including in Keynote 28 and Keynote 158. So we actually do have MSI high data for cholangio. Still very rare, completely agree, but you can't miss it because there is response there. And then the FGFRs to me are just a slam dunk. I mean, response rates of 35 to 45% in a highly refractory patient population. So I think that is a class of drugs that we can't argue with at this point. But
HER2,
I mean,
how would you handle HER2, Dr. Rachna?
HER2 I absolutely give. I mean, I tend to put that, we have a lot of trials with a lot of HER2 drugs, so I don't use a lot of, if the trial requires me to use TRAZ, then I use TRAZ, usually in combination with chemotherapy. I don't use single agent TRAZ. But most of the studies that I have right now for HER2, if they require that, I do that. If not, I put them on one of the many HER2 inhibitors. We've got Zymeworks, we've got Hungary, we've got Purus. There's so many different HER2 targeting therapies right now. So I try to put them on a trial.
Now, any data that you have with the trastuzumab deruxtecan that seems to be, racing ahead for this particular alteration at least?
Yeah, I agree. I agree that to me is the most provocative data so far, and also the most sizable number in terms of data so far. I think the Zymeworks drug is also pretty interesting, but it's still early and small, so we have to kind of see what their drug will do. I also think that there's something to be said about not just HER2 amplification, because we see other HER2 alterations, and I think it would be great to get more data in the HER2 mutation, HER2, because those, I think, those activate that pathway, and I think it's an important group of patients to be investigating in a trial.
All right, so it's 9:30, Viraj. So with your permission, should I be closing? It's late on a Sunday evening. Amol, you want to make some point before I close?
Yeah, because it's JB, I have to speak.
Please.
Otherwise, I will not join next time.
We want you every time that we have a panel, and so we will be privileged to hear you speak before we close, Amol. Please go ahead.
So NGS comprehensive genomic profiling has terrible potential to understand the molecular pathways and simultaneously mechanisms for the resistance. So with our just small experience, I used lapatinib along with the trastuzumab in co-amplified along with the HER2 mutation. Believe me, these are the same mutations wherein the breast cancer patients have responded to lapatinib very well. So I have used trastuzumab plus lapatinib plus capecitabine in second-line setting in this situation, and one patient really gone beyond 1 year. There are another 2 patients similarly. So almost 30 to 40% of the patients are going to have some kind of another mechanisms of resistance. So simultaneously, there are so much of avenues to understand. We had 2 patients of MET amplification. There was such a good response to crizotinib in 1 month, but again, it progressed so fast after 1 month, and he died in just 6 weeks. So what is happening? We don't know. If you read the foundation report, there are n number of chaotic mechanisms. And one very other interesting finding we got is 10% of the patients are having HER3 amplification. And HER3 mutated patients also responded to lapatinib. So there is 65% chance of actionability for treating this disease. And I see a very bright future for Dr. Viraj, and he will be the lead, the person in the country with such kind of, energy and enthusiasm for this cancer. I mark my word, and coming 10 years, all the major targeted therapy will be used in biliary tract cancer.
Great, Amol. Certainly, Viraj will call you for the next panel, if not for anything else, Amol. So this is typically what I call as cautious optimism, which is exactly what you should have in a situation like this. So all of us agree that we should all be moving forward. We should all be moving.
Our publication is a preprint. If somebody wants, I can share.
Please, Amol. We'll be more than happy to read that and educate ourselves. So I think it's very important to move forward, and molecular profiling is the way forward. We may have our problems understanding it, accessing therapies, but that's the way to go, because in a disease where beyond first-line therapy, the activity of all these available agents is hardly any, we're always looking for some opportunity to do better for our patients. And the only way it looks like to get to that target is to get your molecular profiling done and see if you can get access to a targeted therapy. So with that, Viraj, thanks all of you panelists. It was really fun for me conducting this panel. I hope people who are listening learned something today, apart from enjoying this for a Sunday evening instead of watching a movie. Some people probably were sitting with us, so it had to have some entertainment along. Thanks all of you. Thanks, Dr.
All right. Bye-bye.
I know you were busy and you had to come in. Yeah, I'll hand it over to you, Viraj. Let me finish my vote of thanks. Thank you, Dr. Rachna. Specifically, it was a privilege having you and learning from you, because you are the one among all of us who's done it and really shared your experience with us. Thanks all of you, and let me hand it over back to Viraj.
Thank you, everyone. Thank you, all the audience, and an excellent panel, especially Dr. Amol, very, very enthusiastic. And special thanks to Dr. Rachna for taking your Sunday morning time with us. Very, very thank you. And Senthil sir, as always, you are great. Let's have a good night and part away.
Thanks, Viraj. I'll be happy to conduct your next panel also, since you've made it great.
We're doing again.
So don't forget to mention Professor Atul and give him all the support for the clinical trials.
You're more than happy. You're more than happy.
Absolutely agree. Yes. Thank you so much.
Thank you so much.
Thank you, Viraj. Thanks for calling.
Have a good night.
Bye.